2 to 4, right? Okay. My topic today is the chapter 19 of your book, Lung Mediastinum Plura. So bear with me. All of the topics discussed here are based in the book and also based on our experience that I'm gonna share with you and the management of each disease entity. Do you see my slides?
Yes, Doc.
Okay, shall we start? So first in the topic is trachea. So I'm sorry, I am Dr. Buslon. I am a thoracic and cardiovascular surgery based in Bohol. That's why I have this Zoom link and I can meet you guys. Maybe hopefully during the exam I'll be there. So trachea, for the we have the cartilaginous and the membranous part of the trachea. So the anterolateral walls are the cartilaginous and the membranous part in your anatomy in the cadaver, as I hope you'd see it and appreciate, because that is important, especially in management in the trachea, especially to cancer and in stenotic tracheas. So internal diameter normal is 2.3 and the length approximately runs 10 to 13 centimeters long, and it has 18 to 22 rings. It depends on the anatomy and and based on the patient's height also. It begins at the cricoid cartilage and the subglutic space. Again, important to note that subglutic space is the narrowest area, which has a 2 centimeter internal diameter. So again, the blood supply mostly are from the thyroid, subclavian, supreme intercostal, internal thoracic, innominate superior, and middle bronchial arteries. And this blood supply, yes. And these arteries usually located on the lateral wall of the trachea, both sides. So we have first the tracheal injury causes. The common cause is inhalation of smoke or the toxic fumes. So management for this is only supportive, but depends on the initial survey of the injury. So mostly management are supportive with antibiotics and airway support. Oh, wait, I need to hide the respiratory support and airway clearance by fiber optic bronchoscopy. ECMO, this is usually in severe cases already. For lung injury in distal airways and lung parenchyma, but this is so morbid when we have these kinds of patient. So also it has other causes, the aspiration of liquids or solid objects, especially in patients, in suicidal patients. We also have the endotracheal injury from endotracheal intubation from the cuffs of the ET tube or the tracheostomy tubes. We have a blunt and penetrating trauma and also iatrogenic injury. Iatrogenic injury is mostly from post-op or intra-op injuries with other major surgeries. So with tracheal injury, we need to have our institution to be equipped with fiber optic bronchoscopy. We also have, this is just the normal lap tower. If we have, then the other, the first picture is the fiber optic bronchoscopy and the rigid bronchoscopy. These are the barrels for the rigid bronchoscopy. So with tracheal stenosis, endotracheal intubation is the common cause. Again, from usually when patients who suffered from sepsis, CVD or cardiovascular stroke, and in patients who have myocardial infarction or post-arrest patients who underwent endotracheal intubation. That is the most common cause that we could have the tracheal stenosis. Also, it is associated with esophageal fistula or during the course of the stenosis, because again, it is sometimes it also affects the walls of the trachea, that it can cause a fistula, or there's an opening in that connects to the outside of the mediastinal structures, and also with the artery, or what we call the most common artery associated is the innominate artery, that causes also the fistula, that causes severe bleeding or severe hemoptysis to the patient. Also with tracheal stenosis, this could also result from after the radiation therapy, excessive corticosteroids therapy in autoimmune disorders, gastroesophageal reflux disease, and obstructive sleep apnea. But these are rare. The commonest one is from endotracheal intubation. So again, intubation-related risk. So if your patient is intubated for a prolonged time, there is also, if the tracheostomy or tracheotomy opening is through the first tracheal ring or cricoid membrane, that would also cause the tracheal stenosis. Oversized EP or tracheostomy tube. So we need to really measure, or the usual that we use for the endotracheal intubation is 7.5 EP. And for the tracheostomy tube, we could also use the size 6 or the size 8, but usually size 8 is very good with airway in supplying oxygen to the. So history, also again, with history of prior intubation and your patient is intubated again, so that could somehow cause further injury that could cause the tracheal stenosis. And again, traumatic intubation can also cause, sometimes during the intubation, it could create a wound that that would heal, and it will form a scar. Then that could also cause tracheal stenosis. So it occurs between 2 to 12 weeks after extubation or tracheostomy decannulation. So you need to follow up this patient, if in case, especially in those patients with sepsis, myocardial infarction, that most of these tracheal stenosis have less blood supply during the injury or during the intubation period, or during the course of the disease, that it can lessen the blood supply to the trachea and cause for scarring and cause the stenosis. So symptoms may appear immediately or later, 1 to 2 years. Sometimes they present with stridor and difficulty of breathing or chest discomfort. So female is more affected. It presents again with stridor or dyspnea, usually located in the upper third of the trachea. So we have this in your diagram, pictures in your book. We have the type of the tracheal stenosis. So please go over through with it. And this picture on the letter D is the tracheoesophageal fistula, and the E is tracheoinnominate fistula. So we have here the incidence of 2 to 12% in tracheostomy-related tracheal stenosis, severe stenosis in 1 to 2%. Tracheal tube should be at the second or tracheal ring. So when you do your tracheotomy, you need to put or open, or the tracheotomy meaning when you do the opening in the tracheal trachea, you need to put it in the second or the fourth tracheal rings, not on the first. So you need to count during intra-op, and with a transverse incision during tracheotomy. So we have here a patient. This was my experience during when I was in lung center. This was the patient has a tracheal stenosis secondary to post-intubation injury. So acute management, because this patient came in with dyspnea or stridor, meaning there's an obstruction. So we need the immediate management is the fiber optic bronchoscopy to note where is the area of stenosis, then do the rigid bronchoscopy for the dilatation. The rigid bronchoscope can dilate where is the stenotic area, and the surgical management, the is resection of approximately 2 to 4 centimeters of trachea. What we have here in the picture is a tracheal stent that we put with this patient. So in high-risk patients that we cannot do resection immediately for the stenosis, or there is a long segment stenosis, so we need to apply the tracheal stent to dilate the airway. So again, also I have here in the management, so application of self-expandable metallic stent as shown in the picture, balloon dilation, or we could apply balloon or just the rigid scope. We just use the rigid bronchoscope for dilation. We also have a laser ablation, but here in the setting the Philippines, although we have a laser in lung center of the Philippines, but it's so costly also that we could and also less responsive when it comes to laser. The best is the optimal treatment is resection of the trachea. Tracheoplasty, I have done tracheoplasty, but again, when your the PTFE that we use, if that's rigid enough, still it can cause the obstruction because it will collapse eventually. So we also have the allogenic tracheal transplantation using the bovine, but this is rarely used. So we also have the tracheoinnominate artery fistula that is most worrisome and morbid. When you have these patients, you need to go to the OR immediately to identify where the fistula is and where the bleeding comes from. So it is due to the low placement of tracheostomy and a hyperinflation of the tracheal cuffs that it indurates the wall and affects the artery that causes the bleeding. So of course, within 2 weeks, and presents with bleeding or massive bleeding or severe bleeding and hemoptysis. If you've seen these patients, so especially in patients with history of post-intubation or post-tracheostomy removal, so or even in patients with stroke patients with tracheostomy and NGT, sometimes it would cause this one. So management, again, exploration and repair. You need to ligate where the artery is and close the opening. So we also have the tracheoesophageal fistula, which occurs in patients with prolonged mechanical support with an indwelling nasogastric tube, as I have said. So again, management, fiber optic bronchoscopy, and also do the EGD or the endoscopy, resection, anastomosis, where the problematic area is. So when the patients, you need to first wean the patients from mechanical ventilator, remove the NGT. If cannot be weaned from NGT, do esophageal diversion, or you need to do gastrostomy to divert the food supplements for the patient. So gastric decompression, gastrostomy tube, or the jejunostomy tube for feeding. Any questions? If none, then we'll proceed with tracheal neoplasm. So when you have, these are rare type of tumors, but when you see one, mostly it is cancerous. So they have an indolent growth. Most of these patients would present with, again, stridor or dyspnea. And most common primary is the squamous cell carcinoma, which is related to smoking. When you have one, it is very aggressive, and mostly this patient came in with stage 4 already. And The next one is the adenoid cystic carcinoma in 65% of cases. Other types of cancer are the mucoepidermoid cancer, adenoCA, lymphoma, small cell carcinoma. Again, on chest X-ray, you can see with tracheal stenosis in 50% of cases, usually present with advanced stage, mostly here in the Philippines, because screening is very poor in our locality. So we rarely catch up the early stage. Usually it is in stage 4 already, and most of the time it is a metastatic one. So 5-year survival of 40% when detected early. So again, I have here, please, if I say that you study this table or there are words that I emphasize well, mostly that will come out with the exam. Just listen and again, if I say review the table, then you review, okay? So high index of suspicion with cough, dyspnea, hemoptysis, stridor, or horse that patient would present. So do a flexible or rigid bronchoscopy. If you see a lesion, do a biopsy right away. Or you could, if the stenosis, because again, it creates a stenosis because of the tumor. So debride and or do laser ablation if you can. Then do a complete staging through CT imaging or PET scan with mediastinoscopy. Mediastinoscopy is just removing or getting a sample for biopsy. If tumor is resectable, then you do the performance status. I hope you know already the performance status, the ECOG or the Karnofsky status, and because we need to assess our patient for surgical resection. So if the patient has poor performance status, and also the tumor is unresectable, so these are the indication when the tumor is resectable. Please note this one. And also we have the tracheal resection principle. So if we need to resect, the patient must be a good candidate for surgery or with good performance status. So you will resect up to 50% of the tracheal length and lateral mobilization only. Put your head in the forward flexion for 7 days and laryngeal and hilar release as needed for relief of tension. That should be meet up. That criteria should be done during the resection already. If the tumor is unresectable, so probably grossly positive tracheal resection margins, because we need to do a frozen section during the surgery. If the disease is metastatic, meaning it metastasized. Again, as I have said, most of the tracheal neoplasm, although it's rare, but most of them are metastatic. So length of resection precludes safe reconstruction. So if you do not, again, you can resect approximately 2 to 4 cm of the length, and also with the for most of the 4 tracheal veins, if beyond that, so it cannot be resected. So invasion of unresectable adjacent organs. So if it is adherent to the other organs, so it is unresectable already. So you do, if you have that kind of patient, poor performance status, tumor unresectable, then you need to do a radiotherapy for these kinds of patient. But again, this patient mostly is stage 4 already. So we have here I don't know if it will play. Oh. So again, I have here So again, this is just a picture with the this is a squamous cell carcinoma patient. We have done this several times, like complete obstruction of the bronchus. Then we need to do the rigid bronchoscopy to core out the tumor, do photocoagulation for this patient or cryotherapy. Then we need to open up the airway so that we could give better quality of life for the patient. So most of these squamous cell carcinoma are metastatic already. So we just need to help the patient breathe. So after the procedure, we have this picture on the right side that the bronchos open up already. So tracheal neoplasm, again, basic management. You need to do the neck and chest CT scan with contrast or work up the patient for any metastatic or any primary. So rigid bronchoscopy with APC or the coagulation or the laser ablation. Then complete resection with clear margins for primary anastomosis and radiation post-op. So that would be the management for this patient. But again, in our patient, if your patient is poor performance status with unresectable, so you refer this patient immediately for radiation therapy. So next, any questions so far? So did you see my next slide?
Yes, Doc.
Yes, Doc.
So after, if you don't have questions for trachea, we proceed with the lung. So again, as we discussed, with the tumors of the trachea, then we go to the problems of the lung. So first, we have the primary. We have the spontaneous pneumothorax. It is classified as the primary or the secondary. When you say primary, no underlying cause. When you have secondary, it could be there is an underlying lung disease or any infection. So diagnostics, we have chest X-ray and high-resolution CT. So primary, so this is caused by the rupture of apical or subpleural bleb, or in which the cause of the bleb is unknown. Again, it occurs in male, smokers, post-adolescent, tall, thin, male. So we have mnemonics for this one. Tall, thin, young adults, usually this primary pneumothorax occurs. Indications for surgery is first episode, even with first episode but with complete lung collapse, recurrences, or if it recurs, then occupational hazards such as air travel, deep sea diving, travel to remote locations. So you need to have this patient. You have to ask the patient what are the occupation, what are the risks for the patient, because anytime it could happen. But if your patient had deep sea diving, then he has this history of the pneumothorax, that it would be much problematic if it occurs during the diving. So initial management is closed tube thoracostomy. If with early for 3 days, then we proceeded with video-assisted thoracic surgery, bleb resection with fluoridesis. But nowadays, with the advent of minimally invasive surgery, we offered immediately the patients to have the video-assisted thoracic surgery. It would be the prognosis is very good, with the fast recovery of the patient, rather than waiting for the the airlift to resolve for 3 days. So sometimes we offer immediately 4 BATs or the video-assisted thoracic surgery. For secondary, so it could cause, most of these patients have COPD, smokers, COPD, TB, infection, so emphysema, cystic fibrosis, AIDS, metastatic cancer, asthma, lung abscess, lung cancer. So, and also we have this rare kind of pneumothorax, which is a catamenial, occurs at the second or third decade, occurs within 72 hours after the onset of menses, usually related to endometriosis. Nowadays, because of the, again, inflammatory causes of the endometriosis, we have a lot of patients nowadays that has the catamenial problem of pneumothorax. So next is we have lung abscess. So it is a localized area of pulmonary necrosis by an infectious organism. Cavity of at least 2 centimeters. Chronic it could be more than 6 weeks already. Risk factors is advanced age, impaired consciousness, or patients who suffered from stroke. Suppressed cough reflex. This is also mostly associated with stroke. And dysfunctional esophageal motility, laryngopharyngeal reflux disease, and again, I have stated here the stroke patient. So, causes of lung abscess, it is tabulated in your book. So please go through over this and know some of the primary and the secondary causes for the causes of lung abscess. So we have here the necrotizing, aspiration pneumonia, esophageal disease, and immunodeficiency. Or as a secondary, it is bronchial obstruction from neoplasm, foreign body, systemic sepsis. But most common, this lung abscess is found in immunocompromised patients or in stroke patients in our setting. So I have here a chest x-ray with air fluid level. If you see or the x-ray reads air fluid level in your findings, then you have to suspect for lung abscess already. So pathophysiology, aspiration of infected material or foreign body that causes pneumonitis with impaired drainage of fluid or aspirated material that cause inflammatory vascular obstruction, tissue necrosis, liquefaction that cause the abscess formation. This is a polymicrobial disease, which is anaerobes and streptococci are the most common pathogens. Nosocomial pneumonia in 60 to 70% gram-negative, immunocompromised patients, as I have said, especially in AIDS patients with pneumocystis carinii and fungi. So diagnostics, again, chest X-ray and chest CT scan. Mortality in 5 to 10 or 9 to 28% in immunosuppressed patients. Management, again, fiber drainage by fiber optic bronchoscopy. We could do also the transthoracic needle aspiration for culture and sensitivity so that your treatment would be directed to the bacterial growth. Sputum culture, here in the provinces, we don't have this, but in Lung Center, we have the sputum culture for TB, especially if you could get tissue for myco-TB culture. Antibiotics is important with 3 to 12 weeks treatment. Penicillin G, ampicillin, amoxicillin, clindamycin, beta-lactamase, and metronidazole should be added during the course of the treatment. But after 12 weeks, if the abscess has failed the medical treatment. So we have here, please know this one, the indications for surgical drainage procedure for lung abscesses. So we have a failure of medical therapy, abscess under tension. So if you handle these kinds of patients, again, refer this to your TCBS friends for possible drainage procedure. So abscess increasing in size during appropriate treatment, contralateral lung contamination, abscess in 4 to 6 centimeters in diameter. So more than that, you need to drain it. Necrotizing infection with multiple abscesses, hemoptysis, abscess rupture or pneumothorax, inability to exclude a cavitating carcinoma. So that's why we need also to do aspirate these kinds of abscess. Sometimes it could be cavitating squamous cell carcinoma. So surgical management, again, drainage, and these are the others on the table. We have the indication for drainage. So we could do a drainage percutaneous, fiber optic, closed tube thoracostomy, and cavernostomy is seldom done nowadays, but in those problematic patients, we could do cavernostomy. You just open up the area where the abscess is located and clean it and drain the abscess. Also, in problematic patients that are unresponsive to treatment, we could do lobectomy in 10% of patients with 90% success rate. Mortality is less. So next is we have here the bronchiectasis. So bronchiectasis is the pathologic and permanent dilatation of bronchi with bronchial wall thickening. Most of the bronchiectasis found here in the Philippines is from the TB injury from a TB infection. And most of it are acquired because of the infection. So localized in maybe segment or diffuse, infects medium-sized airways. So when you say congenital, it could be from most common is from the cystic fibrosis. It commonly produces a diffuse pattern of bronchial involvement. So when you say acquired, again, I'm sorry for that. So when you say acquired, it should, again, as I have said, this is more common in our locality due to the infection. So usually localized localized from a bronchial obstruction from cancer or inhaled object or extrinsic airway compression. So if you say diffuse, again, it is mostly from infectious. So others are just nice to know. The pathological morphology classification. So mostly when we send the tissue for biopsy, the pathologist would describe it like a cylindrical, varicose, succular form with succular in morphology, which is more of pathologic diagnosis already, which is the succular is more common. So diagnostics, again, chest x-ray, sputum exam, chest CT scan with contrast. Usually, bronchiectasis could cause the most common patient presentation is cough and copious or meaning abundant mucoid secretions. Not only a mucoid secretions, but it is really greenish and recurrent. If you won't remove the bronchiectatic area, you will not see improvement on the secretions of this patient. And these patients would keep coming back to you because of the cough will not be relieved, or it will be relieved just for few days, then it will come back. But again, the optimal treatment is surgical resection of bronchiectatic segment or lobe. There are some lung transplant or for the end stage lung disease or mostly for the cystic fibrotic patients. So anti-reflux surgery could help, but again, airway clearance, chest PT, antibiotics, nebulizations are just supportive management. The optimal treatment is resection of the bronchiectatic segment or the lobe. So I know you have the mycobacterial infection discussed in your, I don't know if you have discussed it already. I'm sorry in your IM, but just an overview. So we also have mycobacterial infections. In WHO, these are 56% affects mostly in the Asian countries, leading infectious cause of death, especially here in the Philippines. Treatment success rate is 83%, but that is 83% was too high in the Philippines setting. It is I can say that the DOH failed to have this TB treated, especially in the urban areas or in the squatters area. So this is we still have these kinds of patients that patient came in for a massive hemoptysis because of this TB infection. So for this TB infection, medical therapy is recommended. So we have the 2-month intensive phase and the 4 months maintenance phase. So I hope you go through with the infection. But again, once you have this TB infection, if not treated properly, bronchiectasis will set in, and that causes also the problem with hemoptysis and the frequent or massive recurrent infections with pneumonia, and again, a lot of mucoid secretions that could again affect the quality of life of the patient and work-related aspects of in the patient. That's why they suit for consults. So, indications for surgery to treat mycobacterial pulmonary infections. As I say, myco-TB or pulmonary TB is medically treated, but in some cases there are patients who really have this symptomatic and needs for surgical intervention. So that's why we have here the indications for surgery to treat myco-TB or pulmonary infections. So number one, we have the complications resulting from previous thoracic surgery to treat TB. So again, the bronchiectasis. Failure of the optimized medical therapy. When we say medical failure, so progressive disease, lung gangrene, intracavitary aspergillosis, and superinfection. So need for tissue acquisition for definitive diagnosis, complication of pulmonary scarring. So we have the bronchiectasis, as I say, extrapulmonary thoracic involvement, pleural TB, and non-tuberculous mycobacterial infection. So that is the indication for surgical treatment for myco-TB. So even in TB, we also have a fungal infections in patients who are immunocompromised or patients who has cavitary TB. Aspergillosis is more common. So when we say fungal infections, most of them are immunocompromised patients or in patients who are undergoing chemotherapy and in elderly patients who suffer from strokes. So these are malnourished, severely debilitated, diabetic, or have a hematologic disorders. So also in patients receiving high dose of intensive antibiotic therapies. So number one cause here in the Philippines is aspergillosis, especially in patients with cavitary TB. So sometimes they have a superimposed infection of aspergilloma that's sometimes cause the massive hemoptysis, and that is our indication for surgical removal of the affected lung. So we have here a massive hemoptysis. So by description, we have an expectoration of over 600 ml of blood within a 24-hour period. It is a medical emergency and associated with a mortality rate of 30 to 50%. So I have here the pulmonary and extrapulmonary causes of massive hemoptysis. Be sure to know this one. And which is, as I have said, TB, bronchiectasis is common in our locality, so be sure to note that one. Management against respiratory stabilization is important. Intubation with isolation of bleeding lung, control of hemorrhage, and prevent asphyxiations. That would be mostly are supportive, but it could improve a lot in the condition of the patient. Surgery, again, the indication for massive hemoptysis is the same with what we have in the indication for TB and the abscess. So we have here a general indication of urgent operative intervention for massive hemoptysis. We have a presence of fungus ball, presence of lung abscess, presence of significant cavitary disease, and failure to control the bleeding. So again, the tables that I have shown is very important. I'll get most of the questions on the table I have presented. So end-stage lung disease. So we have here, these are the patients need transplant. So in Lung Center of the Philippines, we have a program already for lung transplant patients. But in other countries, they have a strong foundation already when it comes to organ donation. So end-stage lung disease is a heterogeneous emphysema treated by low-volume sleeve resection, operative mortality of 16.9%. But as you see, when these kinds of patients are so morbid and presents really with dyspnea that is not medically responsive. If you see one, please refer it to the higher centers already. So 1 year mortality of 23%. So again, end stage lung disease, when we say end stage, so these are candidates for lung transplantation with patients with COPD, idiopathic pulmonary fibrosis. So again, I'll end up this lecture with this. Then I'll give you a break for 10 minutes, 5 minutes only. So that we will finish with the other disease entity.
Yes, Doc.
So our next topic is did you see my slides? No. Okay. Okay, the next topic is lung cancer. So nowadays, most of the patients that came into clinic have pleural effusion already. This pleural effusion is associated with mostly when you see one patient with unilateral pleural effusion, most of the consideration, it could be malignancy or infectious. But most of the patients, especially in patients with 40 years old and above, it is usually malignant. So that is in the Philippine setting. But because our book is based on so because our book is based on US, so and their screening for lung cancer in other countries are very good. When I just want to share that my experience in Shanghai, when I was there for 2 weeks observation in their pulmonary cancer center. Very good. Very even in it's just a ground glass opacity or a very less than 1 centimeter nodule, or if just 0.5, 0.3, 0.8 centimeter, they catch it, and most of the patients have a better survival. Still, prevention is better than cure. So, but here in the Philippines, most of the patients we see in stage 4 already. So, female is more affected in and younger age nowadays is more prevalent with 22.8% and less than 45 years old. White race is also again more affected with 16.1%. So we have a table here which the clinical presentation of lung cancer. So when you say clinical presentation, again, the usual symptoms of cough, dyspnea, wheezing, hemoptysis, or the recurrent pneumonia or recurrent infection, or sometimes they have this pleuritic chest pain, local chest wall pain, or hoarseness of voice. But with hoarseness of voice, that is late symptoms already for the patient, meaning there are lymphadenopathies already on the laryngeal nerve. So we also have this table. This is just a nice to know. So differentiate from nice to know and be sure to know. Okay. So we have here the paraneoplastic syndromes in patients with lung cancer. We have the endocrine, neurologic, skeletal, hematologic, cutaneous, and other. So because when we work up for patients with lung cancer, so it doesn't mean that only the nodule or the mass that we saw we'll just focus in it. But most of this lung cancer, again, have associated paraneoplastic symptoms like hypercalcemia, or these patients with sometimes complain just of muscle pain, or it is associated, but mostly it is associated with anemia. So lung cancer, so when you have these kinds of patients, you need to evaluate them with history, PE. When you work up this patient, when you see a nodule, you work up this patient. The basic one, when you see a patient in the clinic or you have a referral, an admission in the hospital. So history, PE, diagnostics with chest X-ray, chest CT, and other diagnostics like bronchoscopy. If you need to do a biopsy, you need to do biopsy with mediastinoscopy or transthoracic needle aspiration biopsy with CT guided, or other would be thoracoscopy. So again, the basic, you need to do the basic. So before we go further, we'll have to review our anatomy first. So this is just a review. I know you've done it already. So, okay. So the right lung has you need to know that it has a 10. Both right and left has 10. But in the left lung, mostly other books would have say it's 8 or it is 9. So when you say because others in the lung segment has been fused, like for sterolateral basal or the anterolateral basal. But again, right lung has 10 segments and with 3 lobes, and the left lung has 2 lobes with 10 segments. But again, other books have 8 or 9 segments, depending on the book that you are reading. So, anatomy, again, this is important in staging or in prognostication also for the patient. So be sure to note the superior mediastinal nodes, where it is, the aortic nodes, the inferior mediastinal nodes, and the N1 nodes. These are important, especially in lung cancer staging patient. So lung cancer it is non-small carcinoma, or the small cell carcinoma. So if you say non-small, the types are large cell, squamous cell, adenocarcinoma. But when you say a neuroendocrine tumors, we have here also the new classification system for lung. This is for lung adenocarcinoma. But when you say in generalities, when we say lung cancer, non-small cell lung carcinoma, so we have the pathologic description also if it's large, squamous cell, or adeno. But in general, the common one is the non-small cell carcinoma. The other type would be neuroendocrine tumors. So we have here in the new classification, we have a pre-invasive lesions. We have the atypical adenomatous, adenocarcinoma in situ. So these are mostly the ground glass opacities that they say that it is a pre-invasive lesions. If it is minimally invasive already, approximately less than 3 centimeter in size, it could be minimally invasive. Predominant tumor with lipidic pattern, non-mucinous, mucinous. But this is just more of pathologic description of the patient, of the cancer, because as nowadays we have a targeted therapy already. So these are very important. The new classification system is important for the oncologist to know further which targeted therapy they would give for the patients. So when we say adenocarcinoma, most common lung cancer is the adenocarcinoma. So again, they are all non-small cell cancer, but specifically adenocarcinoma is the most common, 80% in histologic subtype. Female is more affected. In female, if you say female, most of the female are non-smokers. But here in the book, these smokers, female is more affected. Non-smokers, equally prevalent male and female. But in the Philippines, most of the female that are affected are just passive smokers. Common in Asian female, as I say, 45 years old, which is non-smoker, asymptomatic, and note that it is a peripherally located nodule. You can approximate, or meaning you can predict that this is adenocarcinoma based on the location. But as diagnostic purposes, we need to do still the biopsy. So we also have the adenocarcinoma in situ as the table says. But when you have this in situ, when they say in situ, this is just a small lesion and with 100% survival rate with complete surgical resection. So other types, we have this is just more of his pathologic description for the patient. So next one, the common one, also the common for smokers are the squamous cell carcinoma. So 30 to 40% of the lung cancer. Again, number one is adenocarcinoma. The second common one is squamous cell carcinoma, but if the patient is smoker, this is squamous cell carcinoma. So male is more affected than female, usually found on centrally. When you say adeno, it is peripheral. When you say squamous, it is central. So again, take note of that one. So symptomatic and can arise from TB scar. So the TB scar, so we need to treat properly the pulmonary TB because it can degenerate into squamous cell carcinoma. Also note that one, cavitation is frequent on radiographic findings. So the other types, the large cell carcinoma, which is 10 to 20% of lung cancer, located peripherally or centrally. So usually 3 to 5 centimeters in diameter. So this is also a nice to know table, the difference between invasive and the non-mucinous adenocarcinoma in situ. So again, this is just the prevalence and the phenotype or the genotype. We will not go through most of that because this is more of pathologic significance. So we also have a lung cancer, which is of salivary gland type neoplasm. So we have adenoid cystic carcinoma, mucoepidermoid carcinoma. When you have these kinds of tumor, also the neuroendocrine neoplasm, this is aggressive tumors. And again, here in the Philippines, we rarely catch up early stage. This is really a late stage, or most of these patients see consult when they are stage 4 already. So again, and when we have the biopsy, so because I've shown you some of the pathologic importance of the tumors because of the treatment that we need to give, especially now that we have a targeted therapy. So immunostains are important. So what are the immunostains for this lung cancer? We have the chromogranin, synaptophysin, CD57, urine-specific disease, and we have the PI57 also. The neuroendocrine carcinoma, again, this is just a nice to know. We have the grade 1 or the low grade in younger patients. Lymph node mets is common. Grade 2, high grade, peripherally located. Also, we have lymph node mets, but this is just a nice to know. I just want to show you that neuroendocrine tumors is grade accordingly, and the higher the grade, it is more problematic. So, grade 3, mostly malignant, centrally located. Patient is symptomatic already. Most of the neuroendocrine carcinoma in the lung presents with pain. So, In grade 4 NEC, this is a pure small cell carcinoma. This is very aggressive tumor, small cell carcinoma with large cell component or combined tumor. So that is for the pathologic type of the tumors. So low dose for lung cancer screening, again, we don't have a good lung cancer program here in the Philippines, but in other countries they have a very good lung cancer screening program. So they have this low dose CT scan even here in the Philippines, only lung center or other higher centers in Manila. I don't know in Cebu, maybe they have the low dose CT scan already. So indications that patients should have the low dose CT scan if the patient has a greater than 30-pack history of cigarette smoking, had smoked within the past 15 years, or a previously smoker for the past 15 years, had no prior history of lung cancer, but when you see the patient which has a nodule, you need to screen them, had no history of other life-threatening cancers in the prior 5 years. So again, you need to request for a low-dose CT scan or did not have symptoms suggestive of undiagnosed lung cancer such as hemoptysis or weight loss. And patients had not just CT scan in the prior 18 months. So that is low-dose CT scan is indicated in these kinds of patients. So solitary pulmonary nodule. So when we say SPN, this is less than 3 cm or less in diameter, completely surrounded by normal aerated lung. So single, well-circumscribed spherical lesion. So when we say it is a mass already, pulmonary mass, it should be greater than 3 centimeters. So again, be sure to note that one. So differential diagnosis could be congenital, neoplastic, inflammatory, vascular, traumatic disorders. But again, if you have SPN, the most that we are consider is malignancy. So diagnosis, just CT to characterize. So note this one, characterize nodule number, location, size, margin, morphology, calcification pattern, and growth rate. Because that is the when there are patients who do not want to have it biopsy directly, sometimes they came back with a larger the nodule become a mass already, and the growth rate is very significant. That's why important to note this character of the nodule. CT findings of benign lesions. When we say benign, this is the description. Small size, calcification within the nodule, stability with when you monitor it, is it stable or does it grow that fast? So calcification is an indication that mostly that kind of nodule is benign. When we say the SPN is problematic or malignant, the growth is increased with 40 to 50% in partial solid lesions, 15% of subcentimeter solid or non-solid nodules, volume doubling time in 20 to 400 days. So it's very fast. When we say benign, the patterns of calcification or common in TB, which is granulomatous infection with a lamellated popcorn pattern. So in malignancy, again, because the growth is faster, usually we catch up those lesion as a mass already. Again, mass because it is more than 3 centimeters. So when we say malignancy, so be sure to note in the CT scan findings, this one, irregular, lobulated, or spiculated edges and finding of corona radiata sign consisting of fine linear strands extending 4 to 5 millimeter outward and appearing spiculated. This word, spiculated. So when we say spiculated, consider it malignancy already. So calcification that is stippled amorphous. So Again, when you work up those patients with new SPNs or request for a low-dose CT scan, so if benign calcification, then you need to follow up this patient yearly or 2 years. If it grows big, so if it's stable, so no further intervention would be required for the patient. But if it is the mass changes in size, is surgical risk acceptable? If yes, then proceed with surgical resection. So again, ECOG status is important during the assessment. So establish the diagnosis by biopsy when possible. Consider radiotherapy or motor symptoms and palliate as necessary if surgical candidate or poor surgical candidate ang patient. Low probability serial high-resolution CT at 3, 6, 12, and 24 months. So when you assess the character of that nodule, so you need to follow up. If low-risk probability of cancer, you need to follow up with 3, 6, 12, and 24 months. But intermediate risk, if the patient has family history, any smoker, so all the risk that has discussed in the table. So additional testing should be done. PET imaging, if available. Contrast enhanced CT depending on the institutional expertise. Transthoracic fine needle aspiration biopsy if nodule is peripherally located. Bronchoscopy if air bronchogram. So this should be done if there is a risk for the patient or when you assess the nodule has a risk. If high probability of cancer, so proceed with VATS. If or again in intermediate probability of cancer, then you can do VATS already for frozen section followed by resection if the nodule is malignant. So it is diagnostic as well. VATS is diagnostic as well as therapeutic for the patient. So PET CT. So again, nice to know. This is just when you have that nodule and it turns out malignant, or if it is the intermediate probability of cancer, you need to do PET CT. But PET CT is very costly. So, but it helps in your diagnosis because it lights up. And if it lights up, it is positive already for metastatic somewhere. Or if the SPN lights up, it could be a malignancy. So increased signatures of glucose uptake, glucose metabolism can be measured using this 18FDG. So 97% sensitive and 78% specific for SPN. So false negative results if the patient has AIS, MIA, or the low-grade in situ cancer, carcinoids, and tumors less than 1 centimeter in diameter. False positive also, this is just a problem. You have the false negative and the false positive results because of the confusion with other infectious or inflammatory disease. So much better if high suspicion, do the biopsy right away. Metastatic lesion of the lung is also common. We have the primary, as discussed already, the non-small cell carcinoma, the large cell carcinoma, and the neuroendocrine tumors. We also have the metastatic lesions to the lung. When we say metastatic, it's mostly a lot of nodules. SPN solitary, as they name itself, solitary pulmonary nodule. But when we say metastatic, it is multiple. Okay, so that is your differentiation already. When I say in the exam, it is multiple, so no. So in your mind, you can say it is metastatic already. So if it is solitary, so choose the one that's the best. What's the best answer? So multiple smooth round borders, temporal proximity to the original primary lesion. Risk new primary lung cancer if patient has uterine, bladder, lung, head, and neck cancer. So these are the most common cancer that are metastatic to the lung. Uterine, bladder, lung itself, and head and neck cancers. So the survival data from IR for lung metastasis. So with complete resection, if it's metastasectomy was done, 36% in 5 years, 10% this is just an approximation for the prognostication for the patient. So metastatic lesion to the lung approach to thoracotomy or VATS, but when we because it is metastatic already, most of these patients are stage 4. When we say stage 4, so you need to have the indication why you're going for metastasectomy or the surgical resection of metastasis to the lung. So these are the general. Be sure to note this one, general principle governing appropriate selection of patients for pulmonary metastasectomy. Primary tumor must already be controlled. Patient must be able to tolerate general anesthesia, potential single lung ventilation, and planned pulmonary resection. Again, we need to be careful with these kinds of patients because these are stage 4 lung cancer, stage 4 cancer patients already. Most of them have limited pulmonary reserve already. So metastasis must be completely resectable based on computed CT imaging. There is no evidence of extrapulmonary tumor burden. Alternative superior therapy must not be available. So again, metastatic lesion could be approached through VATS or thoracotomy. So other non-specific non-pulmonary thoracic symptoms, again, the paraneoplastic symptoms is still associated, again, as I have shown earlier, even with metastatics, we have still the paraneoplastic syndromes. So common when you have the Pancoast tumor, the phrenic nerve palsy, recurrent laryngeal nerve palsy, SVC syndrome, pericardial tamponade, back pain. These are the most common symptoms in patients with lung cancer. So be sure to note each one of that as described in your book. Symptoms associated with lung cancer, again, because when we work up patients for even solitary pulmonary nodule or in patients with lung cancer, that these patients, when we diagnose these patients with lung cancer, so commonly, when we have the PET CT, it lights up everywhere, but common to these areas, to the CNS and 10 to 15%. That's why we need to have the metastatic workup before we proceed with the surgical resection, because we need to do proper staging for proper prognosis of this patient and the survival for this patient. So, and vertebral body and bone in 25% of cases. So lung cancer metastasizes commonly to these areas. Liver, adrenal glands, lungs, skin, and soft tissues in 8% of cases. Vertebral body and bone is the common 25%. CNS in 10 to 15%. So diagnosis, again, as I say, fiber optic bronchoscopy. So there are 3 ways that we can get a diagnosis for this kind of patient. Fiber optic bronchoscopy, video assisted thoracic surgery, and CT guided transthoracic biopsy. So in FOB, we could do the brushing and washings for cytology, direct forceps biopsy of a visualized lesion. So we could also do the EBUS or endobronchial ultrasound, guided fine needle aspiration biopsy for the externally compressing lesions or the endobronchial tumor. We also have the transbronchial biopsy with fluoroscopy to guide forceps to the lesions or electromagnetic. Most of these diagnostics are made for just to get the specimen. So, and with this EBUS and the transbronchial biopsy complication, most of it are pneumothorax in 1 to 3.5%. So other diagnostics, again, basic. When you have the solitary pulmonary nodule or metastatic multiple nodules, you could request for chest x-ray, chest CT scan with contrast. So I have here, even though it's little, but be sure to review this in your book. This is the guided workup or diagnostic for, we have here the step 1 and proceed with step 2 and step 3 in working up for patients with diagnose non-small cell lung cancer or even the large cell cancer and the SCLC. So if you have these kinds of patient, you need to do the step 1. If positive for biopsy, then proceed with the step 2, then the step 3. So in lung cancer diagnosis, again, important is the image-guided transthoracic biopsy. Again, as I have mentioned, complications are pneumothorax. Then we could also do the VATS wedge or direct vision core needle biopsy. VATS is more of diagnostic and therapeutic because if it is malignant, then you can remove immediately. Even if it's benign, then you can do the wedge resection. If it is malignant, you can do the lobectomy already with VATS if the patient is resectable. That's why some other patients, even SPN, and we suspect it for malignancy, we work up the patient already, do the metastatic workup so that we can offer the best treatment for the patient. Then do the proper staging also so that we can prognosticate or refer a patient first for neoadjuvant or adjuvant therapy. Then thoracotomy biopsy also. But then because we need to stage this patient prior to surgical removal also, we need to know heartily our mediastinal lymph nodes as I say in the anatomy. So again, important when we do the staging is the CT scan with contrast for this patient. If greater than 1 cm in diameter of short axis, most of these lymph nodes are positive or 70% predicts metastasis. So even with one pulmonary nodule or if it is a pulmonary mass, if in CT scan, the radiologist read it as greater than 1 cm in short axis view, with 70%, it predicts metastasis. In PET-CT, it would be sensitive in 79% and specific in 92%. So again, when you do PET-CT in your patient, it lights up. So lymph node diagnosis, again, if there are also patients who don't have the pulmonary nodule or pulmonary mass, but they have enlarged lymph nodes. So how can we get how do we do the biopsy for pulmonary lymph nodes or the mediastinal lymph nodes? So we have the EBUS TBNA or endobronchial ultrasound guided transthoracic bronchial needle aspiration biopsy. And these are the lymph nodes that are accessible. So again, be sure to note this one. Lymph node at the station 4 right. So that is the meaning of 4R. Then the station 4 left. So be sure to know what is station 4 left. Station 7, subcarinal, station 10, and station 11. When you say EBUS, accessible by EBUS. When we say accessible for esophageal ultrasound, we have the 4R or the station 4 right, station 7, station 4 left, and the station 8 and 9. So there are specific. We cannot just say that the positive is at the station 9. So you request for EBUS. It cannot be done because there are specific when and how to use this EBUS TBNA and endobronchial esophageal ultrasound guided transthoracic biopsy. And we also have the mediastinoscopy. Mediastinoscopy is accessible only on the subcarinal and the station 2, station 3 left or right. So we can do that with mediastinoscopy or even with much better if you have the video assisted mediastinoscopy. But in our time, we don't have that. Only the mediastinoscopy, direct vision. So with distant metastasis, again, diagnostic for distant metastasis is PET-CT. PET-CT that covers the whole body already, but again, it's expensive. If no PET-CT, you can do the brain CT scan, ultrasound of the whole abdomen, but much better ultrasound, a CT scan of the whole abdomen and chest, brain CT, bone scan, liver, and do the liver enzymes. This metastatic workup is expensive, but this is needed when we do the staging and prognostication for this patient. So staging is important to estimate the extent of the disease, determine patient's prognosis, tumor classified into clinical, pathologic, and clinical or pathologic. So again, I've shown here again, please know this by heart, the mediastinal lymph nodes. So when we say superior mediastinal nodes, so we have the station 1, 2, 3, 4. Then aortic nodes, the 5 and 6. The inferior mediastinal nodes, the 7, the 8, and the 9. The N1 nodes are the hilar, interlobar, lobar segmental, and subsegmental areas. So techniques in the mediastinal staging, we have the endoscopic and the surgical. So indications for invasive mediastinal staging in lung cancers, we have these indications. And we also have indications for pre-thoracotomy, thoracoscopy biopsy of station 5 and 6 lymph nodes. So again, this table 19-10 is important. Please read this one. TNM staging. We have, even though you did not encounter this staging, the 8th staging, but we have the 9th edition already in GNC's American Joint Society for Lung Cancer Staging 8th edition on your screen, but we have a 9th edition already. So because the book in Schwartz still has the 8th, so we follow this 8th TNM staging, okay? But again, as I have mentioned you, we have the 9th edition already. So, and these are the T, when we say T1, where's the, when we say that the, TX, T1, until the nodes, so that is the description, okay? I want you to know that T and M staging, because that is important when we offer neoadjuvant surgical and the adjuvant chemotherapy for this patient. So these are the usual stage group in the 8th edition of the TNM staging. So this is just a nice to know, but this table you should know. So again, patient's preparation again is important. So we have the requirements prior to surgery: smoking cessation of at least 8 weeks. For 8 weeks is recommended for risk reduction, but at least 2 weeks should be encouraged because there are some patients who can't stop smoking. We need to do the pulmonary function test, and these are the requirements. If we need to do the pneumonectomy or the removal of the entire lung, right or left, either side. So if EV1 of greater than 2 liters, if lobectomy only 1.5 liters. If bilobectomy, again, we recommend 1.8 to 2, greater 1.8 to 2 liters for the FEV1. So if EV1, how will we do? How will we know that this patient is a good surgical candidate? Again, ECOG is important, and the ECOG status or the Karnofsky status for these kinds of patient. So after we have that, we need to have the risk stratification by doing the PFT. If the patient failed for the PFT, we can do the CPET. If the patient failed for CPET, we could proceed with DC what's that one? The other test for these kinds of patients. So CPET again, so we have this if EV1, so if the again, if the patient failed, proceed with CPET. So this table here is important. So be sure to know this one. So because if we subject this patient for surgery, of course, after the surgery, we need to also improve the quality of life for these kinds of patient because they need to undergo possible adjuvant treatment or radiation after the resection. So, lung cancer management for this is just in grade 4 neck or neuroendocrine tumor. So, with in patient in isolated lung lesion with grade 4 neck. So again, complete resection with mediastinal lymph node dissection plus chemotherapy is recommended with advanced disease chemo with or without art. So in early stage non-small cell lung cancer, we have the T1 and the T2. That's why it is important to know what is T1. When I ask T1, what is T2? Or what is T3 with T3 without N1? So that's why I need you to know the T and M staging. So again, recommended is surgical resection. For high-risk patient, we could offer them high risk, meaning patients who have comorbidities or failed with our risk stratification. So we need to do the wedge resection or segmentectomy. Still surgical removal, but not lobectomy or pneumonectomy. So, and we could also do the tumor ablation with a relative risk of 27% and the recurrence rate with segmentectomy is 25%. Lobectomy, the recurrence rate. So for early stage cancer or the surgical candidate cancer, is lobectomy is recommended because of the recurrence rate is less. That is the main objective, and the prognosis is good and the quality of life is very good. So, but in high-risk patients, this only we could offer. So, with tumor ablation, so this is just a nice to know. We have the radio frequency ablation. So, I think you can go through over this. This is just again a nice to know indication when to do radio frequency ablation. So, the cancer-specific survival at 2 years was approximately 90% in radio frequency ablation. Excellent local control for primary site. If, again, this is for early stage cancer. Contraindicated. Radio frequency ablation is contraindicated in target lesions less than 5, tumor abutting the hilum, malignant pleural effusion or pericardial effusion. Again, if patient has pleural effusion, because we need to do also fluid cytology. If it is cancer, then that is stage 4 already. Okay, this is nice to know, the tumor ablation. So in stage 3 disease or the stage 3 lung cancer, patients with small tumor that have metastasized to the mediastinal lymph nodes, large tumors who have 7 centimeters and tumor invading unresectable structures, or the major carina with no nodal metastases with a 5-year survival of 28%. So treatment, again, this is very controversial in stage 3, especially in stage 3A disease, because there are other institutions or other surgeons, other oncologists that would still recommend surgical resection. Because sometimes this patient, if we subject them for induction chemotherapy or the neoadjuvant therapy, after the chemotherapy, their body is weak already and not surgical candidate. So again, the assessment is based on the patient performance status and the risk stratification, lung risk stratification for these kinds of patients. Because again, stage 3 disease is very controversial. Because if we say surgical removal right away, the problem is with the disease-free survival for this patient. If we subject them to neoadjuvant therapy, sometimes after the neoadjuvant therapy, these patients would not come back for the surgical removal. So again, case-to-case basis, but by the book, by the guidelines, treatment in the stage 3A is induction chemotherapy with a response rate of 70% plus surgery and adjuvant chemotherapy. With T4 and stage 4 disease, we cannot do so much for these kinds of patients, but chemotherapy with or without RT is recommended. Okay, important to know how to manage these kinds of patients. So, long answer, if we opt only for chemotherapy, so these are the large tumors. But again, stage 4 is very, very unresponsive to chemotherapy. High-risk tumors, when we say high-risk, these are the tumors that are poorly differentiated tumors, moderately to poorly differentiated lung neuroendocrine tumors, with vascular invasion, resection limited to wedge resection, tumors greater than 1 centimeter in diameter, visceral pleural involvement, and lymph node sampling at the time of resection was incomplete. So that is what we say high-risk tumors. So we also have, this is just a nice to know, the induction chemotherapy, the benefits with induction chemotherapy. Again, but the important here is the systemic micrometastases are treated with induction chemotherapy, and disease-free survival is also important. So with induction chemotherapy, so disadvantages, possible increase in the perioperative complication rate in patients requiring right pneumonectomy. So again, as I say, these patients, if they come back, these are not surgical candidates already because of the effects of the chemotherapy after the induction, or that is the neoadjuvant. Adjuvant chemotherapy, so these are the indication for patients who need to have the adjuvant therapy. Any patients with nodal metastasis, N1 or N2, or with a T3 tumors defined as tumors 5 to greater than 5 or less than cm, or separate tumors in the same lobe, direct invasion of the chest wall, includes the parietal and superior sulcus, parietal pericardium feeding. This is mostly mostly found on patients stage 4 already. We could do also the sequential chemotherapy and radiation. So nice to know. This involves the full dose systemic chemotherapy with cisplatin combined with second agent followed by a standard radiotherapy approximately 6 degrees. So the combination of chemotherapy followed by radiation has improved 5-year survival from 6% with radiotherapy alone to 17%. Again, we give these patients these kinds of therapy because 6% or 17% is not a 0%. Sometimes they hold on to the percentage that they will still live, the quality of life that we give or we could offer to these patients. But there are some patients, if you just talk to them properly, they won't go anymore for any therapies. We also have concurrent chemoradiations with administers chemotherapy and radiation at the same time. So we have these terms that you could do sequential or the concurrent chemoradiation. With concurrent chemoradiation, it can improve primary tumor and local regional lymph node control. So, okay, with radiation alone, so palliation of symptoms in patients with poor performance status. These are not very good candidates for any chemotherapy or surgical removal. We could offer radiation, but these are very poor performance status already. Cure rates with radiation as a single model in patients with N2 or N3 disease is less than 7%. So that's why I need you to know what is N1, N2, T3, D1, T2, T3, so that you could understand more when to give these kinds of radiation. So Panco's tumor is tumor in the superior sulcus, including tumors without evidence for involvement of the neurovascular bundle. But this is just included in the paraneoplastic syndrome for the lung cancer. So carcinoma arising in the extreme apex of chest with associated arm and shoulder pain, atrophy of the muscles of the hand, and Horner syndrome. So Panco's tumor, induction chemotherapy followed by surgery is the management of choice, with complete resection was achieved in 76% survival. 5-year survival was 44 and 54 when complete resection was achieved. So again, this is just a nice to know management for Fancos tumor. But again, when we say a tumor, important in the diagnostic and workup for possible surgical removal and performance status of this patient. So please go through over this table. So again, surgical approach is posterolateral thoracotomy or VATS if accessible through minimally invasive surgery. So post-op care for this patient, just because we have discussed already how to prepare the patient, the performance status, recertification in patients who underwent surgery, and what we offer if non-surgical candidate. We need to go through with chemotherapy and radiation. We have the sequential and the concurrent. But in patient who underwent surgery, so we have to, during the surgery, we need to put a chest tube for the drainage for this patient, drainage of air, and also with fluid. So chest tube should be removed once air leak is resolved, and 24 hours drainage of 100 to 150 ml. Good pain control during the course postoperatively, incentive spirometry for faster lung expansion. These are the exercises for them. With the post-op complication of, usually again, because we did one lung ventilation atelectasis, or if you do the pneumonectomy, the post-pneumonectomy pulmonary edema in 1 to 2.5% air leak, and bronchopleural fistula. Okay, so I'll end this lecture. Thank you for listening. If you have questions, you can message me in the chat box. We still have 15 minutes, but if none, I'll see you tomorrow to continue with the other remaining topics for the chapter 19 in the book. So I'll end this with a quote with start where you are, use what you have, do what you can. Good luck, guys, in your upcoming exam for this topic. If you just listen and note what I have mentioned, recurrently mentioned, or if I emphasized in my lecture, you would really have a very good score in my quiz or in the unit exam. Any more questions? You don't have questions, so let's